Hi, it's Dr. Centeno. Sorry, had a little problem with that last feed, but we're back here and I'm back. Was out for about 6 weeks. And so today we're going to talk about an interesting topic. This was actually a patient from this week who came in with CCI-like symptoms. The patient ended up having severe C1-C2 facet arthritis. But everyone who had seen the patient before had just read the radiology report of the cervical MRI. The radiology report just basically said she had some lower neck degenerative disc disease and never even mentioned anything about the upper cervical spine. And the reason why I want to bring this up today and go through this a little bit is that with a routine cervical MRI, often they're not looking at the craniocervical junction at all. And, they tend to look at the bright, shiny object. Now, this actually was a really big, bright, shiny object at C1-C2, but I think the reading radiologist was not used to looking up there, so they missed it. So we're going to have this patient's radiology report amended, but I would like to sort of go through it, show you what the issues are, discuss some of these problems with upper cervical imaging, and the reason why many of these things just get overlooked in the traditional medical care system and by reading radiologists. So again, going to go over, if you're just joining us, what we call WNL, which is supposed to mean within normal limits, but sometimes in medicine means, and we sort of joke as doctors, we never looked. So this is a case of WNL. So let's go ahead and let me go ahead and share my screen here. So we'll do that. And then I'll show these slides and we will head from there. Okay, so going to give us, again, a short didactic lecture, then we'll open it up to questions. You can go ahead and type questions in while I'm talking. I'll get to those once I'm done here. It can be about this topic or any topic at all. So when WNL means we never looked, severe C1-C2 arthritis missed by the reading radiologist. So there's an old inside joke in medicine. WNL, when we write it on reports, is supposed to mean within normal limits. However, the joke is that oftentimes it means we never looked, meaning that it's far too easy for doctors to write, WNL, 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 with a cursory glance at that system or whatever it is they're talking about. So oftentimes it means we never looked. So let's review an upper cervical case of we never looked. And so this is an otherwise healthy elderly woman who related that after a COVID booster, she began getting right-sided headache and arm referral into her biceps. Now, she was seen up in the mountains here in Colorado, and she saw some good providers. She saw a neurologist, she saw a surgeon, she saw a family practice doc, but no one actually ever looked at the films other than the reading radiologist. The reading radiologist basically said she had some lower cervical degenerative disc disease, and that was it. Everything else was normal, or WNL. And regrettably, each successive provider just depended on that radiology report without looking at the images. So this was her MRI from midline sagittal. And at first blush, all we really see is some degenerative disease in the lower neck down here. So pretty credible that at least this stuff going down her arm here could be due to that little disc bulge here at C6-7. Doesn't really explain why she has headaches, however. So the problem is that once you move off the midline here in looking at her sagittal neck MRI, things start to look weird. So as I looked at the MRI, this is the axial, and this is the first axial in the high upper cervical spine. Important to note that most neck MRIs don't really include much of anything above C2-3. This one happened to include just a little bit at C1-C2. So thankfully, I caught this on the axial, but most MRIs wouldn't have gone up this far. So again, just realize if your MRI says normal cervical MRI and you think you have a problem at C1-C2 or 0-1, they're not looking at those levels at all in the axial generally. So here, this is what I'm talking about. That doesn't look right. So we have something pressing backwards here in the spinal cord, and it looks a little odd. So if we look at the sagittal, we see this right here. So it's that piece right there that we're looking at, and it just doesn't look right. That's the C1-C2 facet joint. This is C0. This is C1. This is C2. And I'm still getting those crazy little horizontal lines because of the big screen that I have. So I apologize for that. And so we're seeing the C1-C2 facet joint that's extending all the way back into the spinal canal. And on the right is what it looks like on sagittal. On the left, this is what it looks like here on the axial. So the bottom line is she's got very severe osteoarthritis on that side. That's the same side that she has problems in the biceps, and it's putting some pressure on the spinal cord. So it's certainly possible that this is causing the biceps pain. Certainly possible, since the C1-C2 facet refers pain into the back of the head, that's causing her headache pain as well. So here's the single thing that could be causing both of these that was totally missed, that no one really looked at. And again, just a quick discussion here. I gotta change this here for a second. I'm gonna change this slide here. And we'll put that back up. So if we look at cervical facets here, we see that this is where they tend to refer pain. And all three of the upper cervical facets refer pain to the head. So we have 0-1 here off on the left. That's what that pain referral pattern looks like across many patients. C1-C2 referral pattern, C2-3 referral pattern. So again, all three of these joints can refer pain into the head, and that includes C1-C2. So while her nerve irritation lower neck could be causing her right arm symptoms, better explanation would probably be that 1-2 facet putting pressure on the spinal cord, and that also explains her headaches. So now she's on a different track entirely, right? We're going to treat that C1-C2 facet. She may actually, it's so large, she may actually have to have surgery to get that trimmed back at that level. We'll see how she does with putting high-dose PRP into that C1-C2 facet joint. And we'll probably treat the C5 through 7 area because we can do that easily while we're there, just to cover both bases. So again, this is a lady who was headed down this track of possibly getting lower cervical surgery, all based on the fact that she had multiple providers who were reading the MRI report and not actually the MRI images. We're going to get her MRI report now amended. So hopefully we can have her local providers understand that if we can't help her, someone does need to go in there and trim back that C1-C2 facet joint. So let me stop this and we'll go to questions here. Rishi, I have a PICL coming up on the 5th of December with you. Which of the below should I stop taking in preparation for the procedure, and which ones can I keep taking? Omega-3 fish oils you have to stop for a week beforehand because they can thin out your blood. and cause excessive bleeding during the procedure. And the rest of those are just fine to continue to take. And then you can start omega-3s right after the procedure again. AT, welcome back. Does longer duration holding with AO Nuka chiropractic indicate ligament healing and tightening generally? Yes, I think that's reasonable, or better muscular function, either one. Rishi, I saw you make a video about patients getting their procedure notes after PICL. Can you confirm patients will get the procedure notes the same day after they're discharged? We don't no longer give procedure notes out. That's a formal request. What we will give you is a sheet of paper that has absolutely everything that was injected for your record, so that you know exactly what you got injected. And then if you want the procedure notes, you got to go through the billing department through a formal request, just like you would do with a hospital or any other clinic to get those. They're not going to be all that much different than what we give you that day, though, because what we give you that day is going to be created based on that information. So your notes will be pretty much the same of what you get handed that day. Rishi, I often don't sleep all night before big events. I consider PICL the biggest decision I've ever made in my life, so I'll most likely not sleep the entire night before the procedure. This affect me sleep for the procedure and make procedure more risky. Probably not. If anything, it might go the other way. You might be sleep might be welcome. Rishi, can you explain in depth what an occipital car wash is and what the success rate tends to be in treating occipital neuralgia? Yeah, so when the third occipital nerve is involved, in addition to the greater occipital nerve, you can reach both of those by hydrodissecting the plane above the rectus capitis posterior major. And so that's what that means. We call it an occipital car wash, but that's just a sort of an internal term so that the assistants know what it is we're doing. That doesn't really do much for the lesser occipital nerve way out here. So if we're treating just lesser and greater occipital nerve, we'll treat those directly. But if there's third occipital nerve involvement, we'll do the C2 car wash. Rishi, do you need a low back lumbar MRI diagnosed and proceed with treatment for lower back instability or SI joint instability? Certainly would be very helpful to have, for sure. AT, can AO Nuka care with posture-based PT improve spinal curvature without CBP? I think it's certainly worth a shot. Not necessarily in my experience, but I think it's worth a shot. Rishi, if you wanted my low back SI joint treated, could this be done the same day as my PICL? Only if we think you're going to be able to tolerate multiple areas. I would say about 2 out of every 3 people we see could easily tolerate that. About 1 out of 3 can't. So we'll have to make that as a judgment call on the day. Rishi, why can't body's own stem cells heal neck ligament issue? I have CCI, but if I sprain my neck because I sleep on it the wrong way, it may be sore for a couple of weeks, but goes back to normal. So the body's repairing that. Why can't it repair the CCI? Has the body gotten used to the CCI, doesn't recognize it as an issue? And if so, how with bolus injections? So Rishi, this just has to do, same reason ankles do the same thing, right? If you sprain your ankle a little bit, then it sort of heals on its own. If you sprain your ankle more, we have a complete non-retracted tear or a partial tear, then it doesn't fully ever heal, and eventually you end up getting ankle osteoarthritis due to ankle instability. So same exact concept. As far as orthobiologic injections, it causes another bite at that healing apple because we're causing acute inflammation, sort of re-injuring that area, if you will, and then providing the stuff to help it heal. Rishi, are you working with 5th generation plate lysander? So how far was it available to the patients? We maximized a long time ago the growth factor concentration in platelet lysate. As far as 5th generation platelet lysate, that's more of a platelet lysate type drug. And that's a whole separate conversation having nothing to do with autologous products. Michael, Dr. Williams says stem cell. In Atlanta, I have crepitus very high in cervical levels. When I get stem cell, all symptoms of crepitus goes away. Where can I go to get more testing for C1-C2 arthritis and what other procedures might help longer term? Caymans. Michael, I don't know your diagnosis. If you've got certain types of CCI, then you would need the internal ligaments treated through that PICL procedure. And that's not something that can be done at all in Atlanta. So I would need to know more. We generally don't treat a lot of upper cervical injuries in the Caymans at all. But what you're probably telling me is that you probably have ligaments that are involved that Dr. Williams can't reach because he doesn't do the PICL procedure from the front. I'm guessing that's what I'm being told. AT, could you briefly explain the significance of excessive BAI, BDI translation, flexion, and extension? It's more closely related with type 1C instability. So basically what we're talking about there is a very similar thing that we tend to see in type 1C instability, where you've got movement of the skull against the cervical spine. Now, BDI translation can also be related to vertical instability. But from our standpoint, that's related to a type 1C. What average BDI translation reduction per PICL have you observed? We have not followed those. We followed C1-C2 overhang or type 2B. So I can give you those numbers, but I can't give you BAI, BDI translation numbers. We don't use them. We would use things like increase in grab oaks. Daniel, in which CCI case will C1-C2 posterior injections be enough to improve symptoms? Well, really none. If there's CCI, you would need to also inject the associated ligaments posteriorly. So in general, a type 3A, where you're seeing C2-3 translate forward in flexion, and usually that's C2-3, facet injections and all the posterior ligaments. So that type 3A works well with posterior. If it's a C1-C2 instability, generally posterior doesn't work well. Ash, hey, Dr. C, 9 weeks post-PICL, feels like I have fluid pinching sensation, headache, right side upper neck, difficultly on back, did a pressure sensation pinching our side, unable to wear neck collar, just has CT veno that did state jugular vein compression. So jugular vein compression due to styloids is a normal condition, not abnormal. So I think lots of people have heard me say that time and time again. It's present in a high percentage of the normal population without symptoms. Opinion on CT veno. So again, not sure that there's anything else to do based on that information. And we, as many people know, we wouldn't even start looking at whether or not you have responded to a PICL until you get to that 3-4 month mark. So you're still pretty darn early there. So again, severe bilateral jugular vein compression is found in about 1 in 4 normal individuals. So not something I'm going to be concerned about. Maya, hello, I've had CCI symptoms for almost a year. What I noticed recently is that being more active has improved things a lot. Does CCI get better with exercise, or might it just be spondylosis? Maya, I don't know what type you have, but certainly in all types of neck conditions, getting the cervical muscles stronger is a substantial net positive. So if you're responding by getting better with exercise, that is absolutely wonderful. Ride that train as long as it'll go and see where it takes you. AT, for curve correction, as there's generally traction with extension, would this be contraindicated for type 1C because skull is sliding back in extension? It could be, only if the skull is sliding backwards in extension, meaning that type 1C is either flexion or extension. But ultimately, it's going to be based on how someone tolerates that or not. So there are patients with small amounts of skull extension or sliding and extension who would do just fine with curve restoration, and there are patients that wouldn't be able to tolerate it. Have to do once a year. Yeah, Michael, so same conversation. I don't know what type of CCI you have. There's 8 different types. But in general, if that's what's happening, it's probably because ligaments that need to be injected aren't being injected. Finn, arthritis is always just cartilage, but nevertheless, the cartilage degradation cause instability, even if the ligaments are fine. Not generally instability. Now, what you might see is decreased joint space width, and that is going to cause laxity in the ligaments because you're taking a spacer out of the joint. Finn, can PRP or stem cells regenerate lost cartilage or at least thicken or improve the remaining cartilage? If not, what's the best treatment strategy to stabilize these joints maybe? So it depends on what we're talking about. PRP, I think we have enough studies now to say that it's a disease-modifying osteoarthritis agent, and that means that it can help preserve cartilage. As far as thickening or improving cartilage, if there's small holes in the cartilage, we can see that with bone marrow concentrate. If there's more severe generalized osteoarthritis, that's not going to change with any sort of stem cell treatment. If the osteoarthritis is more severe, then stem cells tend to work better than PRP. Mark, car accident 20 years ago with a blow to the side of the head. Of issues with cranial bones ever since, especially the occiput. If I remember correctly, you found a new upper cervical ligament not too long ago. I think you may have called it transverse occipital ligament, TOL. Would there be anything that could be treated to stabilize the occiput? I do have lower cervical instability when it contribute to craniooccipital instability. Not quite sure what you mean by occipital instability. So if you're talking about more craniosacral concepts of a cranial bone being unstable, then we wouldn't be able to help with that, nor would it involve the transverse. Transverse occipital ligament is going to be the upper part of the dens, and holding that upper part of the dens affixed against the atlas. Ian, can PICL address C0, C1 vertical instability? Vertical instability usually doesn't occur at the 0-1 joint. But if there were, then yes, we could tighten down the facet joint capsule or the capsular ligaments at 0-1. Michael, would it be better to come up to Colorado for these procedures? Yeah, the procedures we're talking about aren't offered anywhere outside of Colorado, so not in Atlanta. So if you needed that PICL procedure, that would be Colorado only. Levon, hi Dr. C, what can pulsatile tinnitus in suboccipital area, which starts a few seconds after standing up, suggest from CCJ, CCI perspective? Not much, other than it could be due to pressure on the internal jugular vein. So that's probably the only thing to get from that. Finn, what does PRP and stem cells interact with on immune disease and joints? I can see it going either way, either repairing the damage or flaring the autoimmune disease and accelerating the destruction. I don't think we have any evidence that it accelerates destruction or anything like that. And then there'd be 2 levels of autoimmune disease, right? The first level would be a medical diagnosis of an autoimmune disease like rheumatoid arthritis. The second level is a much softer diagnosis of autoimmune disease used in alternative medicine settings. So, but we've used PRP and stem cells in rheumatoid patients, obviously a much more severe form of joint destructive autoimmune disease than most of the patients I see, and with good results. John, is re-injury common post-PICL from turning the head too fast, etc.? In general, no. So that's not generally something we see just from turning the head too fast. Sure, Michael. Who do we contact your office to set up tests that you need evaluation to come up to Colorado to get treatment? Probably the best thing to do, Michael, is I'll put my email address down here in the comments, and that's the email that goes to my desk. So if you want to just reach out to me directly, I'll hook you up with the right person. So that's going to go into the comments. That's the email address that goes to my desk. Adina, are there extensive studies stating that jugular stenosis is a variant of normal? There are. So that's why I'm always a little bit dubious when people are getting their styloids cut out in order to treat a variant of normal. Now, if there's evidence that there's some other type of compression that can be documented and there isn't upper cervical instability, then maybe that could make sense in certain situations. But if you get your styloids cut out, you're making the person more unstable. So the presence of cervical instability, upper cervical instability, doesn't make much sense. Adina, I think I have a video on that. So if you just go to my YouTube channel, go into the lives and search those. And if you just type in jugular stenosis or IJV or internal jugular vein, that video will probably come up that shows that data. Brian, does Regenexx Corp program cover treatment for condition that does not make the patient a surgical candidate? We generally don't. So you have to be a surgical candidate. John, are there patients who have had more than 5 PICLs? Pretty rare, John. I'd have to think hard to identify someone who has more than 5, but there may be 1 or 2 out there. But that would be pretty rare. Maya, does mid-back pain also cause muscle pain in front of the stomach, solar plexus area, and lateral abdominal muscles? Just wondering if it's related. It can, for sure. In fact, there was a gentleman I saw who was a radio DJ kind of guy. I was about to kill himself, actually, because he had such severe radiating stomach pain. No one knew what it was. No one had really ever thought to take a thoracic MRI. Took a thoracic MRI, nice big thoracic disc bulge, pissing off the nerve. Did 2 platelet-based epidurals and ligament treatments, thoracic spine, pain went away. But he was right at that point where he was about to end his life because no one could identify the source of the pain. So yes, it's not uncommon to see, but it's hard to get diagnosed. John, which would you say is harder to treat, CCI type 2B or 2A? Pretty similar, so not a big difference between those two. Okay, guys, I know it's my first time back. Any other questions here that I can answer? Happy to do so. Just to kind of reiterate what we talked about, we looked at some cervical MRI data on a patient who had severe right-sided C1-C2 facet arthritis and missed by the reading radiologist. And it just brings up the point that this upper cervical part of the spine is usually not imaged on a routine MRI, and lots of times it's not even commented on. John, thoughts on traction to help relieve a herniated disc? Traction can be helpful in some patients with herniated disc. I don't think it's a panacea. I think it's kind of case-by-case basis. Okay, any other questions I can answer, guys? So just to let you know, now that I'm back, I think my schedule changed. And because it changed, I'll probably just be doing these Facebook Lives on Fridays at 1 p.m. So that's 1 p.m. Mountain Time. That's 12 noon Pacific. That's 3 p.m. Eastern on Fridays. So just to let you know, I'll be doing it every week on Friday unless I'm traveling or have a lecture or something like that. Okay, guys, thanks so much for watching today. Sorry about the little hiccup we had with the stream initially. And you all have a wonderful weekend, and good to be back and talking to you again and answering your questions. Thank you.